NU160, I'm going to do a quick review of just what we covered 2 weeks ago in Unit 1. I know it's been a long time since we've met. So going straight into the content, we started with the history of mental health care, right? So mental health and emotional health is interwoven with physical health. The health status falls within a health illness continuum. So we have wellness on one end and sickness on the other. In this discussion, as we cover it, right, that's that mental illness versus being mentally healthy. And the bodies are going to respond differently to different people. So mental health. So when you're mentally healthy, so the absence of mental illness is the ability to cope with and adjust to the recurrent stresses of living in an acceptable way. So for the most part, you and I, we can all cope as things come our way. Those with mental illness cannot. Mentally healthy people, they can carry out daily living, they can adapt to change, set goals, enjoy life, without any apparent. They can adapt. Those coping skills are going to be the big thing between mental illness and mental health. So mental health is influenced by 3 factors: inherited characteristics, so that's genetics, childhood nurturing, what happens as you grow up, and then life circumstances. So, life circumstances might be PTSD. Someone is going about, inherited characteristics are good, childhood nurturing was good, all of a sudden something happens, there's a traumatic event, PTSD is developed. So mental illness interferes with daily activities, impairs judgments, and alter reality. Remember, I can't say this enough, mental illness is a disturbance in one's ability to cope effectively. So with mental illness, you cannot cope effectively. So brief go through the history. There's not too much y'all need to know, and there is a lot of history in it. Just know in times of war, there are, advances in everything. Unfortunately, it just is what it is. Medicine as a whole, just advances during that. Psychotherapeutic drugs changed everything that was happening. Previously, before this time period, right, so about the 1950s, half of the hospital beds in the United States were in insane asylums. We had no way to treat mental illness. 1956, Thorazine came along, followed by lithium, and everyone was like, this is it. We can fix mental illness. However, we know that's kind of not the be-all, end-all. It helps, but at the time, that's what we thought we can do. Because of those medications, the federal government began a movement called deinstitutionalization. So with deinstitutionalization, we basically stopped committing people to hospitals. So in 1955, we had 560,000 beds. Today, there's fewer than 38,000. Why? Medications. In that time period in the 1950s, with those new medications, we thought it was going to cure everything, and we thought everyone could work on an outpatient basis. We know that is not true. Now, congressional actions, whole bunch of things that your book covers. When we go through this, Medicare, Medicaid, a lot of that in the 1960s led to the release of the institutionalization. That combined with it, community mental health centers were funded throughout the 1970s because of those acts. The big one, in modern times goes through the Mental Health Parity Addictions Equality Act and the Affordable Care Act. So when we look at the Mental Health Parity and Addictions Equity Act of 2008, that basically says if your health insurance pays for something for a medical reason, then it should also pay for it for a psychiatric reason. So it basically forced insurance companies to start paying more for mental health. It's not great, and it honestly doesn't work all that well, but it's a step in the right direction. Affordable Care Act kind of did a lot of the same things, reinforcing that mental health parity, but that Mental Health Parity Act of 2008 is pretty important. So currently, what's going on in the United States? 38,000 hospital beds, right? And it's based on a private insurance model. If you don't have insurance, you're kind of screwed in America. We saw at GBHI in the last, 2 weeks, there's a pediatric patient was looking for a bed for Ash, the Austin State Hospital, and there was a 400 child, waiting list. More than 15% of Americans have no insurance, and more than 75% of Americans are covered through private insurance or Medicare, Medicaid. But that leaves everyone else kind of in a blur where there's nowhere for them to go if there is an issue. And you see high rates of uninsured in those with mental illness. Care settings, inpatient. For those of you who have been to GBHI or going there this week, this is it. This is what an inpatient, care is. Based on need, you have to pay for services, you have to cooperate, and the level of severity and illness are going to be a factor. GBHI takes a high acuity. It's 24 hours a day, kind of stable, and you can be sent there by the way of the criminal justice system. Notification of emergency detainment. Sometimes it's a release. You see that sometimes with pediatric. Go to this facility or go to jail. But it's pretty much we're going to keep you stable for 24 hours a day because you're a danger to yourself or you're a danger to someone else. Outpatient is the step down. You're able to function at home, but you need a little bit more help. There's a few different versions of outpatient care, whether it's an intensive outpatient, a partial hospitalization, or just kind of when you go to the doctor and you see your therapist, you see your psychiatrist. These individuals are safe. That's the big deciding factor between outpatient and inpatient. In outpatient care, you can stay at home and we're not worried about you hurting yourself or someone else. Recidivism is a word that gets mentioned a lot in this chapter. It's a relapse or a turn of symptoms. So you might have someone who is inpatient and they're doing well, and we step them down to outpatient, but because they're so used to being in a mental health facility, you have that recidivism, that revolving door, and what we know as frequent flyers. It's very common in this environment. The community support model, that stems from that deinstitutionalization, a support system in society that can help these individuals. Social workers, therapists, combining housing support, food support, income support, rehabilitation, advocacy, integral care, Bluebonnet Trails are some of our local community support systems. This kind of just goes over the different settings of what you're going to see. So you have that emergency care, right? You see that in hospitals when people go to the ER or Georgetown Behavioral. Group homes, residential programs, you see mostly for pediatric patients or specialized. Partial hospitalization is when you go during the day to therapy all day long, like 9 to 5, this is your job, and then go home at night. Psychiatric home care, just like everything else, nurses can do psych home health. You go, you make sure someone's taking their meds, you check up and see how they're doing. And then community mental health is what we just talked about with Bluebonnet Trails. Case management, that is that step in that community care settings. It's that role that ties everything together, that does everything. You see case management done by therapists or you see case management done by nurses. It could be both. You consult, you link them up, you're doing referrals. I can't afford my meds. Case management kind of, if someone can't afford their meds, you might help them find some programs to help them. It looks to make sure everything is stabilized for the patient. Multidisciplinary healthcare team, especially in psych, we work together as a group. Psychiatrists, that's your medical doctor who prescribes medications. Social workers usually have a master's in social work. They've done all sorts of extra clinical hours. They do therapy along with kind of that case management linking up in society. Psychologists are a PhD. They don't prescribe medication, but they do a lot of therapy and testing. Psychologists were great when I worked pediatrics because we would actually test like the IQ. We can see how the kid learned. We could see their processing speed. Those ink blot tests that you used to see old school, psychologists do them. Client and family are involved in the multidisciplinary team, and clients contribute. It kind of prevents duplication of services because everyone is interacting together and you have multiple people's viewpoint about what's going on. Population. Certain groups are at high risk. Homeless, children, families, adolescents, older adults especially, people who have HIV, veterans, high rate of mental illness in veterans, and then clients who live in rural areas. If you stick this together, a homeless older adult with no support in a rural area, it's going to keep increasing your chances. If you throw in low income, right? An older adult who has low income, who does not have transportation, who lives in a rural area, who can't get to their appointments, and they're a veteran, it puts them at a much higher risk. There's a lot of services for those with specifically HIV that they can use, that they can have access to, that can help them a lot. That's pretty much all this is. Impact of mental illness. A lot of money is spent, millions of dollars yearly, on mental illness. 25% of the world's population will have some type of mental illness in their lifetime. And they're going to be struggling with a lot of different needs. Poverty, homelessness, the substance abuse, throw in Alzheimer's disease, AIDS, it just keeps increasing. Forgive me for skipping through that really fast. Okay. Ethical and legal issues, values and morals. Attitudes help shape our viewpoint. Belief is something that we think is true. It does not have to be based in fact. I believe XYZ is my belief. Value is something that's formed in childhood. It can change over time, but it's something that we hold dear. I value my time with my family. And then morals kind of ties everything back together. These are not easily changed. Everyone has rights, and rights help define social interactions because of the principle of justice, right? In healthcare, we should strive to treat everyone fairly. Every patient should get treated in the same way. Client Bill of Rights started in 1972, and then it kind of changed over time. You see now there's even a Teen Bill of Rights and certain things more with mental health care. Care provider rights. We have the right to be safe. I have administratively discharged patients from facilities or called the police and had patients arrested if they're threatening us or they are purposely targeting staff. It becomes a gray area in psych. But we have, as providers, the right to respect as individuals. We have rights as nurses to be equal members of our team. And all healthcare providers have the right to look at what we are doing and the policies and procedures in our facility that affect our patients. Ethics set a rule or values that govern behavior. Ethics ties together those values and morals along with what's right and wrong. In medical, you see it referred to as biomedical ethics, medical ethics, bioethics. But when we break it down, those are those nursing principles we all learned about, right? We have a code of ethics as nurses. Autonomy. Every patient has the ability to make, their own decisions. Beneficence. We try to do good. I can never say this word. Non-maleficence, right? Do no harm. Justice, treat everyone equally and fairly. Confidentiality, respect everyone's information. Don't be telling people who was just admitted to the psych ward. Fidelity, if you tell the client you're going to do something, you need to do it. Especially in psychiatry, fidelity is very important. Hey, yes, I can help you, getting this, just give me 10 minutes. You need to do it. But then also veracity, tell the truth. If the patients are asking you about the side effect of medication or the legal implications of their order of protective custody, you need to answer it truthfully. And if you don't know, you need to help link them up. Hey, I don't know the side effect of these medications. Let's go talk to the doctor. I'm not really sure about how the order of protective custody works. Let's link you up with the patient advocate. So as nurses, we especially need to take steps towards these principles. It is very important for you to have an understanding of how these apply, especially to psychiatry and mental health nursing. Codes of ethics, International Council of Nurses, the ANA, all of them. It's good to know. and be familiar with. This helps guide your nursing practice. I will tell you right now, the ANA, Code of Ethics is a good 70-something pages. And then there's a extra book for it that's another 250 pages almost. So it's a lot, but if you ever have any questions about what's going on to back you up, this is more just an FYI, good to know. Ethical conflict, right? That's that dilemma. You think something should be happening, but what is actually happening is different. And it could be the way the facilities run. It could be the patient posing difficulties. It could be, you see this a lot as a new nurse. They've written books on it. You learn things in nursing school, you get on the unit and it's different. Sometimes, emergency medications, those order of protective custodies, that's what leads to those ethical dilemmas, and where those knowledge of, what is beneficence, what is the code of ethics for nurses comes in handy. When we're trying to make an ethical decision, you need to look at the whole situation, assume everyone is acting in goodwill, right? That everyone wants to resolve the problem, get as much information as you can, look at the values, look at the ethical principles that are involved, take action, implement a plan, monitor change, and evaluate the effectiveness of the plan. Laws in the legal system. Laws are the controls by which society governs themselves. United States has laws, Texas has laws, Travis County has laws. These are based on the principles of justice, change, and standards. There's criminal and civil laws, which kind of falls into that public and private. Public is that criminal law, misdemeanors, felonies. I've always been taught, especially as a nurse, these are going to be your violent crimes. Private laws are between citizens and institutions. Those are your torts and contracts. So this is civil law. You make an error, you hurt a patient, and you did it on purpose, especially after Hurricane Katrina, way back in 2005. You were seeing nurses and doctors being tried for murder because they had given patients too much medications to end their lives. If it was done purposely, that would be a criminal law. Civil law, it gets a little difficult to kind of speculate, but that's going to be someone suing you maybe for like negligence. Legal concepts, nurse practice acts, institutional policies, and standards of practice. Those guide our judgment and our practice as nurses and what we should do. And we need to know what it says, right? So those standards of practice and those nurse practice acts, that's at who, what, where, when, why. What can you do as a nurse? There is a specific book for psychiatric mental health nurses put out by the American Psychiatric Nurses Association on specific standards of practice for psych nurses. The American Nurses Association publishes one every year, every few years, for nurses in general. Nurse practice acts go through the state. Texas has separate nurse practice acts and guidelines, but then Texas as a whole has a bunch of different codes that then break down nursing practice. So there's a lot to it that we need to be aware of as nurses. So laws of mental health care. Client-caregiver relationship is a contract. We enter into a contract, and there's the concept of liability that states that care providers are legally responsible for our professional obligations and behaviors. Clients still retain the rights to their legal rights when they enter the care system. So this is the whole, when a patient is admitted, can we force medications upon them? No. Even if they're on a notification of emergency detainment and we are forcing them to be in the facility, we cannot force them to take medications. There's a whole bunch of different ways to get admitted, right? Voluntary is you walking up to a hospital and you say, I want to hurt myself, I need help. Involuntary, in the state of Texas, you need a police officer. They come, it's 1 to 2 pieces of paper, and they say you need to be there. If it's an involuntary admission, they cannot be forced to take medications. If they're involuntary and they're getting worse and they're not getting better and they're refusing to take medications, then As a hospital, we can sue the patient and we can take them to court, and then the court can order medications. This is all done above nursing, but we need to be aware of it because we'll be the ones giving those medications and forcing the medications. Potential liability. Common crimes in the healthcare setting, right? Homicide, controlled substance violations, theft. We need to be aware. Areas of liability could be if a client's walking up and down the hallway and they're shouting loudly and waving their arms. Can we forcibly restrain the patient? Nope. They're not threatening everyone. If you restrain the patient at that time, it would be assault. If a client's family member calls and asks for information and we don't have a release of information, we cannot give that information out. We need to have a release of information and be giving out information which is in the release. Fraud, false information, right? We can't tell them something that we know is not true. So we can't document that we did something if we didn't. Defamation, saying something against someone that we know is not true. Assault, threatening a patient. If you do not stop that right now, I am going to get a shot and I will give you a shot, is technically assault. We are threatening that patient. The behavior might not warrant a shot. They might just be being annoying to us. Battery, touching a patient without their permission. Gets into those gray areas of psych because sometimes we do have to physically restrain patients. But if you restrain a patient and was not a reason to, and we go back and watch the video and see that restraint wasn't needed, you can be charged with battery. And I know nurses who've had that happen to them. Negligence and malpractice. Negligence, you don't do something that a reasonable or prudent nurse would. You don't round on your patients when you need to. Malpractice, failure to exercise an accepted degree of professional skill that results in injury, loss, or damage. So something happens. So a nurse physically restrains a patient because they're just being annoying. They're punching walls, they're yelling and screaming, but they haven't hurt anyone. She just needs to get this done, so she restrains the patient. That could be false imprisonment. If a physician orders a treatment and says this needs to be done immediately, and the nurse does not do it immediately for whatever reason, it could be negligence. There's a lot more to both of those. That's the basic decision. Forgive me, I'm not used to using my mouse at home, and I keep accidentally skipping the slides. So to be considered negligent, you have to have a duty to the client. You did not carry out the duty, a breach of contract. The client was injured as a result, and there was actual loss or damage resulting from the actions. So if you have a suicidal client who needs to be continuously observed, that's our duty. But you go to lunch, leaving the client alone on the unit, that's a breach of duty. During this time, the client commits suicide. So that's that injury. And dies. The damage. We are guilty of malpractice because no prudent or reasonable caregiver should leave the client unattended. Care provider's responsibility. We help them cope with problems. We need to provide humane and dignified treatment. This is the worst days of their life. We also have a duty to warn. We touched on it briefly. You don't need to know the name of it, but the Tarasoff case is the specific case from 1976 where a patient told his psychotherapist that he wanted to kill someone. They did not warn, was discharged, and he went and killed the person. It is our right if your patient is saying, when I leave here, I am going to go kill my mom, we need to warn the mother. We have to do that. Culture. Culture is a huge one. It's our way of life. Shared systems and values. It makes us who we are. Right? Race describes a group of people based on physical characteristics. Well, ethnicity is associated with the customs and cultural and socialization patterns of the group. a learned pattern that shapes one's thinking. We need to be cautious in psychiatry because not every behavior that you see in a culture is going to be socially accepted, and it will come into play a lot. So knowing the parts of that cultural assessment are going to be very important. Spirituality and religion play an important role in culture. Spirituality is that belief in something greater than a human being, while religion is going to be more defined and organized. You will often see mental illness of religious components. So if a client starts talking to you and asking you about what your religious beliefs are, we need to avoid that. That's a time when it is okay to avoid the conversation. Characteristics of a culture: abstract, values, beliefs, and it develops over generations, formed by feelings and convictions that are believed to be true. Beliefs about mental health have a strong impact on the outcomes of treatment. If you believe, the study in West Nigeria, they do not believe that schizophrenia is a biological illness. They believe it is caused by a religious and spiritual component. That is going to hinder the outcome of treatment in mental health. Stereotype. We all know stereotypes, right? May take negative, positive, traditional forms. Prejudice, extreme negative stereotyping. As healthcare providers, especially in psychiatry, we need to be aware of our prejudices. There's going to be a lot of difficult patient situations, involving individuals who are homeless, involving individuals with substance abuse disorders. As a whole, culture is learned, transmitted, shared, integrated, contains ideal and real components, and is dynamic and continuous involving. An individual's behavior is not necessarily representative of the culture, and a lot of this is going to be in table 4.1 in your book. Influences of culture: health and illness, Western medicine, folk medicine, traditional health beliefs. I've had patients who wanted to put salt around the building. So we put salt around the building. It didn't hurt anyone. It was supposed to keep the spirits out. Disease is a condition in which physical dysfunction exists. Culture, while it has no impact on disease, but illness and its attendant behaviors are influenced by culture. Different cultures over time believe different illnesses exist for different reasons. Navajo, traditional African American cultures view health as harmony with nature. Chinese cultures consider health to be the balance of positive and negative energy forces. We've kind of touched on this in the last few slides as we went through. Members of our culture may define normal and abnormal behaviors differently from those outside the culture. Hence why we need to know what is part of a cultural assessment. We need to know how to do one to assess the different situations. Stress and coping. Adolescence is stressful. Women are often placed in more stressful roles as a result of their cultures, and ways of coping with stress can be culturally determined. In some environments, certain things are going to be more accepted than others. Cultural assessment. Cultural competence is the process of continually learning about the cultures with which we work and developing cross-cultural therapeutic healthcare skills. All providers must guard against our tendencies to transfer our cultural expectations onto our clients. And we have to make sure we're not generalizing based on our own cultural attitudes. Cultural assessments allow us to learn how clients perceive and cope with their world. What we're going to look at in a cultural assessment is going to be communication, both verbal and nonverbal. Environmental, how the individual perceives he or she controls the environment. Space, territory, and time. It's going to be different for different cultures. Social organization, the meaning of the family. Some cultures, the family is a much bigger role. You might have multiple generations living in one house. You might have, the male head of the family who makes all the decisions. Biological is going to be different among different cultural groups also. Certain cultures are more predisposed, certain ethnicities, to different illnesses. So using a narrative summary, when we do that cultural assessment, and again, box 4.1, we're going to look at the cultural identity. We're going to look at how the culture explains the problem, how culture affects stressors, how cultural factors relate to the psychosocial environment, cultural factors relating to the level of functioning, the cultural elements of the relationship between the client and the care provider, and the overall cultural assessment for the diagnosis and planning of care. So, in a cultural communication assessment, you have verbal communication and you have nonverbal communication. So in verbal, language, music, written language, how we talk about emotions verbally, in the most generic and simplest form, men. Men are not going to communicate emotions, especially verbally, as well as females. Touch and space. And we talk about this when we talk about in a few more slides, and I apologize for the dog in the background. He likes to talk to me at night. Touch and space. Some cultures are going to be more touchy, and they're going to have less personal space than others. America's kind of right about in the middle. Refugees. When we talk about culture and mental health care, we cannot discredit refugees, and we can't forget about them. Because of war or persecution or whatever reason, this individual is fleeing their home. They're fleeing their country. They're fleeing their state. Stress-related problems, anxiety are a huge factor. PTSD is an anxiety diagnosis. Something traumatic happened. Something's going on. They're being persecuted. They've now traveled. They've lived in refugee camps without access to anything. You see much greater dependencies of depression, anxiety, and stress disorders. Stress, anxiety, huge problem in treating refugees. Space, I copied this directly from your book. It's figure 4.2. Intimate distance, right? That's you and your significant other, right? You get close together. Personal space, you and your friends. You're sitting around, you have no problem sitting next to them in class, sitting next to them in the coffee shop. Social distance, that's kind of us and our patients. You want to have that space between you. Public distance, right? That was me standing up at the front of the class 2 weeks ago. I'm there, y'all are out in front of me, right? America was somewhere in the middle. Different cultures will be different. So Bulgaria, Peru, Argentina, no personal space. They will come right up into your intimate space. Romania, Hungary, Saudi Arabia, they're going to keep it into the social distance. Theories and therapies. There is a lot for this. Remember, all we really need to know is the basic understanding of most of these. So a theory, we learn from the past. Something has happened. We've been practicing as a nurse. We notice a trend. Hey, in the last 20 years I've been a nurse, I've noticed X, Y, and Z. And then you go and create a theory. They explain various aspects of our human behavior, especially in psychiatry. Historically, Darwin, survival of the fittest. The biggest animal is going to win, and that is not the one who's yelling at me right now. Attila. Right? That's it. If you're impaired or unsuccessful, according to Darwin, you are less likely to make it. Psychoanalytic. That's Freud, right? Look at this picture. Freud is the one who started the let's sit down and talk about your feelings. Your unconscious thoughts and emotions have a strong effect on your behavior, right? So that's that id, ego, and superego. If you go and Google a picture of the id, ego, and superego, it looks almost like an iceberg. Half of it is hidden. That's in our unconscious. We don't know that it's there. But that unconscious is controlling a lot of our behavior. So that was Freud. Sit down on a couch with a therapist. Let's talk about our behavior. Defense mechanisms is one of the things Freud came up with. Remember, on test 2, we will be covering defense mechanisms in depth, so do not memorize defense mechanisms right now. Denial, fantasy, projection, we use those subconsciously as a way to push back unpleasant thoughts and feelings. Okay. Psychoanalytics. Carl Jung divided the mind another time into 3 different conscious, unconscious egos. Extroversion, introversion. He just kind of took Freud a step further. He's not honestly all that important. Stack Sullivan is a really big one, honestly, in my opinion, in psychiatric nursing. He looked at that, our relationships, healthcare providers with others, how can we help them grow? Piaget has theories of how you develop over time through cognitive and affective. He divided different ages into groups. It's going to be table 5.2 in your book, kind of how we grow over time. More important, I think Erickson, he looks at the life cycle in 8 stages, and each stage is going to be marked by different tasks or different crises. You have to finish those tasks before you move on to the next one. Trust versus mistrust is when you see a lot in children. If you don't learn that you can trust the adults around you, then you're going to go with the negative attribute of mistrust. And it's going to affect each other developmental stage and your life as you grow up. Another one you see commonly in psychiatry and mental health is generativity versus stagnation. That you're going to see, I want to say it's like ages 60s, 70s. It's that retirement age. You're so used to working and being productive, you've raised your kids, and now you have nothing to do with your life. Stagnation, generativity. Do I want to be productive? I was forced to retire, now I can't. It's that internal struggle with Erickson. Behavioral therapies, Pavlov, dog and a bell, easiest way to think about it. Every time he would put the food down for the dog, he'd ring the bell. And after a few times of food and bell, when he started putting the bell down, the dog would salivate and he would think, oh my gosh, it's time for food, just from the bell. Because the dog had learned, I hear the bell, I get food. It's kind of a way to help change behaviors. Watson and Skinner, honestly, not too much you really need to know about them. They looked a lot about learning principles, operant conditioning throughout time. Humanistic theories are important part of today's theories because it looks at the individual. Looks a lot about unresolved, with Frederick Perl's unresolved past conflicts. Present, freedom, responsibility, what we can do to help someone become whole. Maslow's hierarchy of needs. Cannot stress the importance of this enough, and we're going to talk about this a lot in clinical because this is the basis for how you come up with nursing care plans, pretty much. How we prioritize that nursing care, especially in psychiatry, right? So the bottom, those physiologic. Without those, we die. Safety and security, love and belonging comes next, esteem, and then self-actualization. What can we do to get to one's full potential? But without air, water, food, shelter, rest and sleep, right? We can't get past that first level. If we can't get past that first level, those physiological needs, we'll never make it to self-actualization. Rogers, client-centered. He worked a lot with kids and kind of new forms of self-psychotherapy kind of built on Maslow's, looking at that self-actualization. Holism, holistic healthcare, looking at the whole person. Systems theories, how everything kind of affects each other, right? They view humans as a functioning within a set of related units, which is the systems. This looks a lot, some of them with like the equilibrium. Cognitive theories and therapies. The main goal of all cognitive therapies is to take your dysfunctional beliefs and thoughts and change them. Cognitive restructuring, let's look at coping skills, let's look at problem solving skills, right? Cognitive is what can we learn to change those negative thoughts. This is different than cognitive behavioral, because cognitive behavioral looks at those thoughts and then the behavior that comes of it. So cognitive therapy, you're laying in bed, you're asleep at night, you hear bump, you start to panic, oh no, someone's breaking into my house. So if we were to adjust this in a cognitive therapy type way, we would change your thought process. You're laying in bed, you hear a bump in the night, and you think, oh, that's my silly dog walking. And you don't get to that panic point of someone's breaking into my house. Cognitive behavioral therapy, you're laying in bed and you hear a bump in the night. You start to panic because someone's, breaking into your house. You jump out of bed ready to start a fight. In cognitive behavioral therapy, we'd work how we can change that action. While in cognitive therapy, we would only work to change that dysfunctional thought process. Coping skills. These are improved, especially in anxiety management, by training. If you're in the middle of a panic attack, I can't teach you how to take deep breaths. It's not going to work, right? So when we talk about coping skill therapies, it's teaching the patient ahead of time. What can we do to reduce the physical response of stress? And we're going to do it early, usually through modeling. Problem-solving therapy, how to solve your problems in a more constructive way. That's going through steps. What is the problem? What can we do? Make a pro-con list. Let's choose the best option. Let's evaluate it. Social cultural. Some of these aren't necessarily the most positive. We're going to be touching it, right? So Thomas, I can't ever say his last name. People are responsible for their own behavior. Mental illness is a myth. We honestly have proved that, disproven that over time. So as a whole, psychiatry has evolved over time. Stress adaptations theory, we're going to talk that a lot, especially when we get to stress, that alarm, resistance, exhaustion, how our body does. Something happens, we start to get alarmed, our body starts fighting, but our body in a stressful period can only fight too long. You do not need to know this table. I honestly copied it straight from the book. It just kind of shows in that alarm reaction, there's a lot going on. And in exhaustion, right? Decreased energy, we can't adapt, death. And that could, in theory, be from stress. The psychobiology, how does genetics, how do our neurotransmitters, viruses, how do we develop as a whole? This is the nature, part of the nature or nurture. Psychoneuroimmunology, how does our immune system interact? How does all of it come into play to help or to hinder our interactions, and our psychological basis as a human, as an individual, right? This looks at neurotransmitters a lot, neuropeptides, different neurobiochemical systems. Y'all don't have to get too much into this. Nursing theories. We all know Florence Nightingale, right? Illness as the body's attempts to repair itself, right? She wrote her book in 1859, right? That started a lot of what we do as nursing. Hildegard Peplau, Interpersonal Relations in Nursing in 1952. She's considered the mother of psychiatric nursing, right? All nursing therapy is designed to help clients in achieving their highest possible level of wellness. So psychotherapies as a whole, right? Treating the mental and emotional disorders by psychological rather than physical means. Online, individual, group therapies, right? Self-help groups. Self-help groups are going to be a lot of individuals who have the same disorder. I cannot go and lead a breast cancer support group because I don't have breast cancer. Alcoholics Anonymous is the perfect example of a self-help group. These play a huge role in psychiatry and mental health, those self-help groups. It's, individuals who come together with the same disorder, with the same problem to help each other. Somatic therapies, these are going to physically affect the body in some way. So medications, right? Medications for mental illness does not affect your mental illness. It affects your brain. Electroconvulsive treatment therapy, that's that old school electric shock therapy. Phototherapy, right? Sitting in front of a bright light can help with some mental illness, such as seasonal affective disorder. So different ways we can physically affect the body. Future therapies, right? Feminist women's therapies continue to grow. Creative aggression therapy, teaching clients how to fight fair. Let's redirect your aggression. Don't be fighting with all these other people. Go take up boxing. Movement therapy, bring the body in line and restore balance. There's a whole lot coming, and that has only been started in the last few years. Neurology, psychology is still kind of a new field. CAM, complementary and alternative therapies. Biologically based practices, aromatherapy, right? Certain smells, certain essential oils can promote certain well-being. Dietary supplements, dietary ingredients can help, whether it's in the diet or as a pill. Certain herbal products, GABA is one, that can be used to alleviate suffering, especially mental illness. Eye movement desensitization, it's a newer one. It's only been around probably the last 20 years. You've really seen it start to be used more frequently. A lot with PTSD. Controlled eye movement helps reprocess traumatic memories. Massage. I would love to get our insurance companies to all cover massage for everyone, especially for nursing students. Manipulation of muscles and connective tissue relax the body. Phototherapy, right? When we talk about depression, seasonal affective disorder is caused by a lack of sunlight during the day. So for treatment, we sit patients for 20 minutes at least per day in front of a light that mimics the sun. Energy-based, I don't know too much about these. It looks at different energy fields. There's veritable and putative. Shows us that illness results when the body's energies are out of balance, and you use different therapies to restore the amount of flow to the body. So other different types of complementary alternative medicine that you can see in mental health: animal-assisted therapy, service dogs, emotional support animals work if people do it right. Cultural-based healing, different cultures are going to have different disease. You still see, the burning of sage. Diet and nutrition, expressive therapies are going to be talking. Pastoral counseling is still huge. Different religions have different, ways that they come together as a group to help each other. Self-help groups, we can't talk about that enough. Individuals with the same problem coming together. And then stress reduction and relaxation, right? Putting ourselves first. What can we do individually to help ourselves heal? That is a super brief overview of Unit 1. We'll be hitting Unit 2 tomorrow. I know probably you all won't get to this until after class. If you have questions on any of this, please feel free to reach out to me over the next few days.